Let's now tune in to the poster sessions by our authors. And thank you very much for your submissions. Have a wonderful day.
Good morning, everyone. Thank you, T, very much for that nice introduction this morning, a nice welcome. We're going to get our day started with taking a look at some additional posters from the Poster and Innovation Hall. We will start with presenters representing posters 11 through 14. And this morning, that will begin with our team, Tamara Bakewell, Brittany Tagliaferro-Lucas, and Rachel Ford.
Hi, good morning, everybody. My name is Tamara Bakewell. I am the family representative on our Oregon EMSC Advisory Committee. And I am really happy to have you here to hear about our project out in Oregon called Hero Kids. I'm going to turn it over to my partner at EMSC, Rachel Ford, to introduce herself.
Good morning, Rachel Ford from Oregon EMSC. I'm the program manager in Oregon. And thank you all for being here this morning, and I'll turn it over to Brittany.
Good morning, I'm Brittany Tagliaferro-Lucas, and I'm the program administrator for Oregon Center for Children and Youth with Special Health Needs. And I serve also as the project manager for the Hero Kids Registry project, which is what our poster focuses on. The Hero Kids Registry project aims to create a statewide registry which will provide key health information for registered children to EMS and emergency department professionals in the event of an emergency. The system will be available 24/7 for EMS and EDs through a hotline, app, or direct linkage with EMS electronic patient care records. And we're building it upon proven technology from the Oregon Post Registry. The project will be registration will be family driven, and it's a partnership between Ocean, Oregon EMSC, families, and numerous other stakeholders. It's being administered by the Oregon Health and Science University, and we're really excited to say that we anticipate to launch next fall in 2022. We look forward to hearing your questions.
Thank you. Next, we're going to move to Greta James Maxfield.
Hi, my name is Greta James Maxfield. I'm the Texas Parent to Parent Family Support Team member and a fan for the EMSC here in Texas. And my project is addressing healthcare inequities that have long plagued our nation, particularly focused on Black, formerly enslaved Black Americans and their ideas about what welfare and healthcare and a community resourced plan for their well-being would look like, and dovetailing that with more recent ideas coming from liberation movements throughout the 60s and to the present. I think that my poster is particularly timely given the recent legal indictment of a couple of paramedics in the state of Colorado, and the concerns about mistreatment that occur at the hands of publicly paid first responders.
Thank you. Next, Scott Oglesby.
Hello, my name is Scott Oglesby. I'm a critical care paramedic and a PhD student. I'm also a EMSC fellow, and I'd like to give a shout out to Corey, Mark, Mo, and also Rachel Goodman for all the work they've done in the knowledge management domain. So briefly, we know that adverse childhood experiences, or ACEs, have a host of negative health outcomes in adulthood. Now, we were screening parents and caregivers for ACEs in the pediatric emergency department in hopes of tying their needs to effective resources in order to help address SES issues. A total of 2,932 parents and caregivers were screened, and we determined roughly 9% had high-risk ACEs scores. This is consistent with previous literature. Our community health workers who are also known as promotoras de salud, they provided proportional intensive support and child psychologist referrals. Really, we were after breaking the cycle of toxic stress and child abuse or non-accidental trauma. Additionally, in the future, we'd like to conduct cost-effectiveness analysis to determine whether it's effective to position community health workers in these PEDs as opposed to additional resources such as social workers or maybe additional unit hours for our nursing staff. It was a great privilege to work with this team. They're really fantastic ancillary personnel. I had conducted data analysis and built their database. Additionally, I was responsible for the research components such as study design and IRB approval. Thank you.
Thank you, Scott. And next up we have Brittany Nichols and Vicki Peterson.
Morning, everyone. I am Brittany Nichols. I coordinate the EMSC program in Kansas, and I'm here representing the Heartland EMS for Children Coalition, or HEC, and answer any questions you might have about our virtual pediatric symposiums. This was actually an idea that we had come up with pre-COVID when we met in February of 2020. But as you can imagine, about a month later, we had to pivot kind of hard because the need was now more urgent than ever. Classes were starting to shut down for public safety, but providers still needed Con Ed to recertify and maintain their licensure. So together we had to work through a few hurdles, one of which was technology, as none of us have a background in IT. We found Zoom to be the option that worked best for us, but if this is something other states are interested in pursuing, we encourage you to play around and find an option that's going to work best for you. And then we also needed to figure out how to navigate continuing education hours across the 6-state region. All of our boards of EMS operate a little bit differently, and so we each handle the EMS CEUs on our own. However, we've partnered with Children's of Minnesota, and they're able to provide the CNE and CME that we offer to our nursing and physician attendants. And the regional partnership has really helped to offset not just the labor, but the cost. So together we can offer this free and robust pediatric education across all of our states. I'm really happy to say we launched about 1 year ago, in September of 2020, that we hosted our first session. And since then, we've been able to provide 13 education hours to about 5,000 attendees. And we've covered human trafficking, poison prevention, children and youth with special health care needs, how to de-escalate children in crisis. And we're planning to keep going because we've gotten some really good feedback that we've used to kind of tweak our format. Our next session is actually going to be October 19th and look at traumatic pediatric burns. But overall, my biggest piece of advice, I think the biggest thing that we've learned from all of this is just that collaboration is key. And I think all 6 of us would really encourage you to work within your own EMSC regions just to see what you can accomplish together. I know all 6 of us have put our contact information up on our poster, and that QR code that you see there will also take you to our HEC region YouTube page where you can watch some of the previous recordings from sessions we've done. So happy to answer any questions and happy to be here.
Thank you very much. All right, we are starting to get some questions in. So the first question is for the team for poster number 11. Registries for complex medical needs children and adults typically require a lot of care and feeding to keep current. Can you speak about how you will be handling those challenges? So that's going to be to Tamara, Brittany, and Rachel Ford.
Take that question. So currently our plan would be to build into the system an automatic trigger, which will prompt our operations staff to send notifications to families on an annual basis to update information. We also intend to educate providers and other stakeholders that interact often with children with complex needs to prompt them to have discussions about their Hero Kids registration and ask that they update it often, and especially if anything changes in their condition.
Thank you very much. All right, some additional, people are still putting questions in, but some questions that came in through the poster hall itself. For Brittany Nichols and Vicki Peterson, what strategies have you used to market your sessions? Just as you guys have said in your poster video, you have grown pretty significantly with your viewership. So how did you do that?
Yeah, Absolutely. So one of the ways we kept costs down is we've done all of our own internal, design for certificates, registration flyers, promotion, and all of that. We use both Adobe and Canva. And really, it's just a matter of, using your contacts, using your networks. I know, for example, in Kansas, we have a Board of EMS listserv that we use. There's a trauma region newsletter that goes out quarterly. And I think other states have done very similar things, so talk to your big partners, KHA, or I guess that's the Kansas Hospital Association, whatever your state's hospital association is, the Emergency Nurses Association, just all those partners who help you get your work done day to day, they're going to be your best resource to get that information out there. And technology is your best friend, mass emails, no one likes them, but they definitely kind of help get that word out.
Thank you very much. Next up is for Scott Oglesby. How are the community health workers trained? What is their background, and when they're integrated into the ED, how did that occur?
That's a really great question. And unfortunately, I'd like to mention that the community health worker program was put on pause during the pandemic. We felt that we just couldn't put them at that higher level of risk, being that they aren't formally trained medical personnel. Additionally, there were budgetary concerns at the same time. But to answer your question, I believe New Mexico is a leader at the forefront of involving community engagement. And we've had a formally established community health worker program for, I'm guessing, roughly 5 to 6 years now, where similar to an EMS license, it is a licensed type of position. And there's standard continuing education requirements involved as well. Regarding our team, I believe 99%, if not 100, were bilingual. While this wasn't necessarily a per se requirement for that position, it was also encouraged. So really, you're involving members of the community who might not become involved in quite a licensed capacity as a paramedic or a nurse, but additionally, they are from the community, so they can interact and engage at a higher level than sometimes our medical providers can.
Thank you very much. For Greta James Maxfield, how we have started with implicit bias training here at the All-Grantee meeting. How can we continue? What can we continue to do? That's a start, but what can we continue to do?
I think that we need to really open up the room so that the space is inhabited by more than the predominant demographic that's there now. I think that it's very difficult for practitioners to gain self-awareness without the gaze of Black and brown people, but particularly Black people. We are the ones that seem to be persistently and consistently coming up with poor outcomes that are unexplained by anything other than race. And while I know that there's something to be said about implicit bias, but then there's also explicit bias, and then there may be just a lack of self-awareness that can be really improved by including at all levels of hospital and care personnel some integration. More community health workers, and especially EMTs. Part of my poster is about the history of the EMT, or of the emergency medical services, and how much of that started from a yearning for personal safety, public safety, and crisis care in Black communities. Many, during the 1960s and 70s. That would be at a time when many of the population might have been displaced because of rampant violence and lack of opportunity in our southern states. And so, their relocation to these urban centers created all types of public safety issues that included problematic encounters with police and with other members of the community that, perhaps were not all that happy about the lack of control over this population. So it's definitely about putting people in places that traditionally have been sort of white space, and allowing practitioners to have real practice at interacting with those people, as well as with perhaps mentoring, and even providing a type of apprenticeship program, so that there are many different ways to come into the professions that care for our health. I think that right now we have sort of a very restricted pipeline, and that pipeline is obviously not serving us well.
Thank you. Really excellent.
Thank you for the question.
Yeah, thank you. And then next up we have Brittany Nichols and Vicki Peterson. Let's see. Do the pediatric symposiums cross state lines during the same session, and how do you address continuing education credits in different states for attendees?
So we host them. Thankfully, we're pretty much all in the central time zone. So we're able to host it all across that single time zone. And then as far as navigating continuing education across states, again, we each handle the EMS CEU specifically, just kind of depending on how our different boards of EMS handle those. So that's kind of, again, handled individually. Just check with your board of EMS on, what regulations you need to follow in order to provide EMS CEUs. And then Children's Hospital of Minnesota has partnered with us to offer the CNE and CME accreditation that we need. And generally speaking, most of your nursing and physician credentials, as long as it's certified through one state to meet the ANCC credentialing requirements, you'll be good there. And so that's just kind of how we've managed to handle that as far as providing education. We're kind of looking into some future logistics because our audience has grown to also include, not just nursing and EMS first responder community, but also every now and then we'll have social workers, law enforcement teachers. So we're kind of looking into the future about how we can maybe, offer them maybe something more than a certificate of attendance. But it's been really exciting to see it grow across multiple disciplines like that.
I bet that is exciting. For Tamara, Brittany, and Rachel, question: How is identity able to be confirmed in the nonverbal child, for these patients?
In the instance of a child that wouldn't be able to speak their own name, we will rely on bystanders to relay that information, but also we are going to provide each child with a registry ID sticker and a backpack tag. So we would be hoping that one of those items would be with the child at the time of an emergency, and EMS would be able to use that sticker with the name and ID to access their information in the system.
I like the idea of some kind of tag or sticker. That's a great kind of gap to fill that. So that's great work. Scott, were the surveys done in English only? You did?
Thanks. That's a great question. They were both in Spanish and English. Unfortunately, we didn't have capacity to include any additional languages. For example, some Native American languages are some of the most predominant languages spoken in New Mexico, in addition to Vietnamese. We have somewhat of a unique population, so we felt that if we could reflect the CHW team construct similar to the population at large, that would be a really good approach to take. Additionally, I want to point out that there's some CHW groups that are quite active on tribal lands and Native American reservations, and I really think that's an important area of focus in the future as well.
Thank you. This one goes again to Brittany Nichols and Vicki Peterson. Regarding the virtual CEs, have you recorded the sessions to benefit a wider audience?
Yes, so we have recorded most of them. A few of them we haven't been able to record just because, different speakers have different, allotments for what they're allowed to have recorded. but we have made all those available that we can on the YouTube channel. Unfortunately, we're not able to offer continuing education for providers who watch them retroactively, but I mean, at least we're able to get the education out there and share it. Like, especially some of them as far as like poison prevention and control, those are really good to be able to go back and watch later with your agency. And that's something else that we have encouraged agencies to do is, don't just register individually, but for EMS agencies, we've had them, watch as whole groups, and we've gotten a lot of really good, robust attendance that way.
Thank you. And then Mark Minkler just put in a comment regarding the attendees. How do you handle the load of that? Like how do you share, since you're a network, how do you share that kind of, I will bridge off of that. How do you share that workload?
Absolutely. No, it has definitely been a group effort. Especially, I think our first one, human trafficking, we had over 1,000 people just register for it. Thankfully, Zoom has made that really easy just because we can download the attendee reports in a spreadsheet. And we can go through and see who's in each state. And so each of us handles our own state attendees. We're responsible for following up with them if they have questions, making sure that they get their certificates. And then for states that are for attendees who come from different states, we usually kind of split that up. Like, for example, I'll usually take Missouri just because Missouri is right across our state line. But it's been a real group effort. And again, I need to thank all of the HEC ladies who I know are listening because could not do this without them. It is truly a group effort. And that's kind of how we just split the whole workload. Someone will be responsible for making the flyer. Someone else will be contacting the speaker. Again, that's why we really encourage everyone to work within your regions because you can accomplish so much more as a group than I can't imagine trying to do this on my own. Coordinating a speaker, managing hundreds of attendees, it would be very overwhelming. But just because we're able to do it together, it's really manageable.
Great, thank you. And then for Tamara, Brittany, and Rachel, how quickly can this information truly get to EMS providers or to ED staff?
We are basing our technology on the Oregon Pulse registries, and in their use case, the average call time to the hotline is under 1 minute. So typically the information would be relayed within one minute to 90 seconds.
And it's faxed? Is it faxed or just verbally given over the phone?
So information would be verbally relayed through the hotline, and then the information itself could be faxed to the ED as they're transporting. So the information would be there waiting for the child upon arrival. And we're also looking at direct linkages to EMS ePCR, as well as development of an app, which would also make information accessible in a very small amount of time.
With the Pulse registry, is there an issue with hospitals not allowing that connection between data sharing in that sense, or access to their EMRs at all? Have you run into that?
No, we haven't. So our connection with emergency departments, we're going to connect with the Oregon's emergency department information exchange, which is in every hospital in Oregon. So that connection is already there. So I don't expect to run into that issue.
All right, thank you. And then one question for Brittany Nichols and Vicki Peterson about how long are your sessions?
So right now we tend to do our one-night sessions for about 2 hours tops. And that was kind of a trial and error. We've done a couple 2-night sessions and those have worked out well too. But when we did one longer set, we did one that was about 3 hours and each presenter had an hour and a half to speak. And, we have an evaluation that we send to all attendees after each session. And we found that 3 hours is a little long for people to be stuck in one place, that Zoom burnout. So, we did have a 10-minute break built in between, but we took that feedback. And now for one speaker, we'll do up to 2 hours. And then if we're going to have, multiple speakers, we'll usually split that up over 2 nights. We did have a brief kind of mini session for EMS week to celebrate EMSC Day, where we had that was just like a 1 hour, but that was more of it was a laugh and learn with one of the EMS comics. So again, just kind of trial and error there. But yeah, 2 hours is about the max you can expect someone to comfortably sit and pay attention and learn before they need to get up and stretch.
Excellent. And then one additional question for the Heroes project, have you thought of recommending using Medical Alert to help facilitate information sharing?
I'm actually not familiar with what Medical Alert is. I'm not, if somebody's on the
Yeah.
If we could put a little bit more detail in the chat, perhaps.
Sure. It might take a second. There's a little bit of there's like a delay, so it might take a second. But Pat, if you want to put in with medical alert, we can clarify that for you. There's also a question about obtaining CAPC to overcome the multi-state EMS CE recognition. Have you guys looked into that and done a cost comparison between doing it on your own or using that process?
We've looked into CAPC a little bit, I believe. As of right now, we've just been doing it individually, again, for cost saving measures. For example, I can speak for Kansas. If we submit retroactively, that's a free process. We just have to make sure we're providing the objectives, all the information about the course, and then the certificates of attendance. But that's something, again, each state kind of handles individually, and we've looked at ways to bridge the multi-state sectionality of it. And I'll have full disclosure here. It's been a big learning curve for me navigating the EMS world of CEUs because I come from the nursing side. So I think everyone kind of has that like little interdisciplinary jump when they're trying to navigate another discipline's continuing education. But we're going to continue working on it and trying to make it better and easier for all of our attendees.
I agree. That is a big learning curve when you're trying to bridge that gap for sure. And let's see if we have any more questions. I'm waiting to see if we've got, Rachel, your link for Hero Kids was shared in the group chat. And I don't see any more questions. Is there anything any of the presenters would like to add? Just one kind of last parting discussion or point? Anyone would like to add anything real quick? No? Okay. Go ahead, Brittany.
Oh, yeah. I was going to say that a lot of what we've been talking about here is about peer support and how there are many roles within the healthcare and the human care infrastructure that needs to really be built out. And a lot of these ideas, they're not new. They're quite old ideas. And the more that we can use those sorts of supports and innovations that are actually old ideas, the more we can decouple, a person's wealth and status from their ability to access healthcare.
Brittany, I think you had something you wanted to add.
Yes, I just wanted to thank everyone for their questions. And if anyone has any additional questions, please reach out to herokids@ohsu.edu. Since the outset of our project back in 2019, Hero Kids has been a 100% collaborative effort, both on the ground in Oregon, but also nationally with partners across the country. So we really do value your feedback and input and ideas. So please reach out. Thank you.
Thank you. And there was a clarification regarding the medical alert, the bracelets. And have you contacted or worked with them at all for this project?
Oh, that's very interesting. So I also used to work with the Oregon Pulse Registry, and the idea of medical alert bracelets being used for registry ID numbers had been brought up. So in that instance, we provided information to registrants on our website of a number of vendors who might provide, or they might purchase those bracelets from those vendors, because as a government agency, we weren't allowed to recommend one. But that would be something that we could suggest to parents that they do, but we wouldn't be able to guarantee that EMS will be able to look for that as the place where the registry ID will be found, because the training that we'll do with agencies would be to look for that backpack tag or the sticker, not necessarily a medical alert bracelet with a registry ID number on it.
Great, thank you. All right, so thank you to all of this first session speakers. We appreciate you all, and thank you for sharing your work with us this morning. We are now going to have the opportunity to hear from presenters from posters 15 to 19. So if you have questions, you can start putting them in the chat for that, and we will get started with Drs. Veronica Campanella and Caleb Ward.
Hi, I'm Veronica. I'm excited to talk to you a little bit about our poster, just a little overview, background information. About half of pediatric EMS calls are for low acuity problems that may not require an ambulance to transport, overuse of this EMS system is both inefficient and unsafe. So there has been interest in how to use alternative disposition systems that could help address this problem. Some alternatives include transport to clinics, dispatch ride sharing, and leaving patients at the scene. COVID-19 has heightened some of these interests with both EMS and patients desiring to avoid unnecessary transports. The picture on a poster showed some that DC is currently using, but thus far for children, they have been excluded in this and many other pilot programs. One cited reason is concern for patients and parents and caregivers would be opposed to these alternatives, although there was very little research to support this claim. So our objective, and thanks to the Family Advisory Committee that helped conceptualize this, was to explore how caregivers perceive these risks and benefits of including children in these alternative EMS programs. We did 6 virtual focus groups, 1 in Spanish, using primitive sampling to ensure demographic diversity of our region with respect to race, ethnicity, and insurance status. Participants agreed on some themes of benefits and potential harms of using these alternatives. Some benefits, overall themes include triage nurse lines could educate caregivers on what is an emergency. It can minimize wait times, and it can be cost savings to both individuals and to healthcare systems. And potential harms included some triage decisions might not have been pediatric trained. They may need secondary transport, delay in receiving definitive care, unsafe transports in ride sharing, and there could be worsening health inequities. Uniformly, parents strongly express belief that caregivers should have final decision-making on whether their kid was brought to the ED or an alternative disposition. These caregiver perspectives should be considered in developing alternative EMS dispositions for children in specific to help ensure that they are patient-centered and acceptable to the population served. The pandemic heightened this need to think innovatively to try to meet with DC for further research to do evidence-based patient-centered transport tools for EMS.
Thank you. All right, our next poster is by Dr. Michael Goldman and Megan Petrocelli.
Good morning, everybody, and thank you so much for taking a look at our poster and inviting us to be with you today. I'll give you the real quick and dirty on our work. It's an early phase where the group in Connecticut recognized that we have some specifics that make our state unique, and that it's a rather small state and also has 2 major children's hospitals. And so we aimed to develop some tools to help community hospital providers organize safe and family-centered transfers within our state. And in order to do so, we had to engage lots and lots of stakeholders in this endeavor. I think nothing new to this group, of course, with this type of work. But first and foremost, I'll call everyone's kind of attention to the middle pictures there, which I know are a little bit small, but on the left is our EMSC transport poster. And we would imagine this would be stored nearby one's EMTALA forms that would be located in an emergency department. Again, this is really for the providers. It serves as a reference to say what modality, what indications would select specific modalities to use. And then as you'll see all the way on the right-hand column there, there's, the ambulances and the helicopters to note that most of the time in our state, we're going by ground, just again, because it's so small, we have proximity to the 2 major centers, but there are, of course, times to activate air. And then the bottom half of this poster is out of recognition, again, that and geographic location, you may choose to transfer the patient to Connecticut Children's or Yale Children's or out of state, and again, to some of the hospitals in New York City or Rhode Island. So we have all that contact information there. And then I think as important as this poster was, we also wanted to develop something that was really family-centered, an opportunity for the provider to slow themselves down and sit next to their patient and their caregivers and really go through why can't we do what you need done here at this community hospital? What do you need to make this next step feasible and safe and family-centered? And it can be as simple as what are the COVID protocols for the parents when they go to the next center? Sometimes parents travel several hours and then they realize only one of them are allowed to come in with the patient. So stuff like that to make that big night of theirs a little more friendly. We use tons of stakeholders, as I mentioned, representatives from children's hospitals, the 2 children's hospitals in our state, EMSC folks, the Family Advisory Network. We had a graphic designer who was way talented, and of course, members of our community hospital advisory group. So happy to field questions. Of course, our next steps will be, hey, does this do anything? Does it make for more seamless, error-proof transfers? Does it make it more family-centered? And we'd be super open to hear your feedback or ideas with respect to either quality improvement projects, of how this tool can be looked at to measure that we're doing good by our families. Thanks.
Thank you. Great work on that. Our next poster is going to be with Dr. Samantha Mishra and Brandon Hausbeck.
Good morning, everyone. I'm Brandon Hausbeck, and I'm a fire officer EMT from Saginaw, Michigan. Also a pediatric champion and co-founder of Carter Kits. Carter Kits provides equipment and training for first responders to utilize when they're treating patients with sensory needs or disorders, such as autism. And I also have Dr. Sam Mishra here with me.
Thanks, Brandon. I'm Sam Mishra. I'm the EMS for Children coordinator in the state of Michigan. I was actually working on trying to develop a statewide resource for our first responders related to autism spectrum disorders and sensory processing disorders. And I realized there wasn't a lot of material that was concise and evidence-based that I felt comfortable to put together for a kit for our pediatric champions in EMS and fire. And when I met Brandon and learned about Carter Kits, I was really excited because they actually brought on the assistance of Dr. Ellen Preen, who is a clinical neuropsychologist who has dedicated her professional and personal life to working with children who have autism spectrum disorder and other sensory processing disorders. And so with the assistance of the Carter Kits team and working with the EMS for Children program here in Michigan, we actually utilized our pediatric champion network and roster as we grew it to reach more first responders. And this poster really strives to share with you a little bit of our timeline of how we strive to bring excellent education to our first responders and have them start talking about autism spectrum disorder education, as it is an area that we have found across the board just really isn't heavily trained upon. And many of our folks just really stress that they did not feel comfortable taking care of kids on the spectrum. So this has been a major mission. We've incorporated it into our COPEM, our Committee on Pediatric Emergency Medicine here in Michigan. It's been a very big mission for the EMS for Children program, one of our major projects. And on the far right-hand column, we also emphasize some of our deliverables, which are in the form of podcasts. And some of them have actually been moved over and housed on American CME, which offers CAPC accredited approval education credits for EMS and first responders. So our contact information is located on the bottom right side, and the QR code will take you to the site as well. And like everyone else has said, we're here to answer any questions and really excited to share our collaborative success with you guys.
Thank you. Next, we have Drs. Isabella Sanchez and Liliana Morales Perez.
Good morning, everyone. I'm Isabel Sanchez from Puerto Rico, and Puerto Rico is a territory of the United States. However, it faced multiple challenges due to limited resources and problems with infrastructure. As you have seen in the news, we suffer from frequent hurricanes, earthquakes, and power outages. That affects our pre-hospital care, both in personal and resource availability. Currently, there's no data available about the comfort or needs of pre-hospital providers caring for pediatric patients in Puerto Rico. The objective of this study was to assess how comfortable paramedics feel stabilizing children with life-threatening conditions and injuries, and to evaluate the availability of pediatric protocols, equipment, and medications necessary to treat pediatric patients in the pre-hospital setting. The majority of responders were EMT paramedics that had been working with the EMS system for over 10 years. The life-threatening conditions which the responders were most uncomfortable managing in the pediatric population were cardiac arrest and child abuse. Regarding education, we found that the most common barriers reported for participation in pediatric educational courses were cost, availability, and time to participate in courses. This study identified the needs of pre-hospital care providers in Puerto Rico. With this information, our next step is to develop a pediatric educational curriculum in Spanish, targeted to the resources available on the island. Thank you.
Thank you. And next is Dr. Benjamin Lang.
Good morning, y'all. My name is Ben Lang. I'm over in Austin, Texas at Dell Children's. I'm working with Annabelle Kramer and Kate Rimick, as well as some of the paramedic educators. on a project really designed to enhance communication with paramedics talking to families after the death of a child in the field. This has really been pushed by the fact that research is showing that high quality CPR in the field enhances outcomes and decreases morbidity and mortality in pediatric patients. And so there is more ongoing CPR occurring in the field. This then creates a situation where a lot of paramedics and first responders are now declaring death in the field when previously they weren't doing that and did not have training in it. There was work done by Mary Fallett and a group of researchers in Kentucky that really looked at this and saw that there wasn't enough education and that families wanted more communication and first responders wanted more education. So they designed a curriculum about how to talk to patients in the context of a pediatric death in the field. They trialed that and were able to show that it was very effective in enhancing communication amongst first responders. And we are now trying to take that curriculum and show that it is something that we can disperse amongst a pretty diverse group of first responders, not just paramedics, but also EMTs and any level of training of first responders, as well as a mixed kind of rural and urban area. So we, over the coming months, will be using that curriculum in 3 different counties here in Central Texas, with the hope of being able to demonstrate that it is effective, but also show that paramedics like using it. We have designed a web app that paramedics can use. There's a few photos of some of the educational materials that we will be demonstrating, and then we'll be running simulations to be able to create active feedback after paramedics use this this curriculum here. We will primarily be looking to see if it enhances first responder comfort with like being able to communicate the death of a pediatric patient in the field, but we'll also be looking at some specialized communication measures to determine whether first responders are learning from this curriculum here. In our initial kind of studies of this, it's really been something where people have really liked it and really found it helpful, but it also is something that has brought up a lot of pre-existing trauma, just because first responders see so much death and so many hard things. And so we're also working with paramedics and with local resources to be able to figure out how best to be able to enhance this curriculum, not just in the how to better support families, but also how to better support all first responders in the context of this. We appreciate any thoughts y'all have on this curriculum, and look forward to hearing everybody else's thoughts at any point.
Thank you. All right, I'm going to open this up for our live Q&A session. Thank you to all the presenters for those summaries of your work. First question is for the Connecticut team. Could you share your EMSC transport guidelines for providers and EMSC pediatric transfer checklist? Are those open for sharing?
You know, I have to think about that for a second. I mean, the immediate response is, of course. I just want to be very clear. We haven't validated or tested it within our state. I think we're more than happy to share it so people can look at it and think through which aspects of it pertain, like work well in their state, et cetera. But I just want to be clear. We're not presenting today that like this is the solution to a problem. This is more, we're just presenting our iterative approach into how we develop these tools that certainly need to be validated, if you will. But yeah, we're all about collaboration. Be happy to share our tools for sure. How should we do it?
I will tell. So the easiest, the poster hall, most of the posters have contact information for all of the authors. So you can easily go to the poster hall, look up the poster, and then get the contact information on that as well. Perfect. If you want to contact the authors directly. Next question is for Carter kits. How much are the kits? And are they one-time use only, or how, for the smaller agencies, how do they absorb these costs for that?
Sure, I'll take that one. So we have two sizes of kits. We have a main kit that is $79.99, and then we have what we call a Carter Kit Junior, which the only difference is whether or not there's a weighted blanket or not. The Junior kit is $45. The weighted blanket's obviously the biggest cost item in there. Now, what we've done to help alleviate the issue of budgets and things is really all an agency has to do is make that initial purchase. Once they do that, we have a nonprofit arm that replenishes the items as they use them. Some of the items are reusable. The blanket is washable. The earmuffs are able to be decontaminated, but the toys, the sunglasses, those are pretty much one-time use. So the nonprofit is where we replenish them when the items are used.
That's great, thank you. For Drs. Campanella and Ward, did caregivers provide insight on what the ideal non-ED disposition was?
We pushed them a little bit on what the features would be, and folks, if they could be seen in their primary care medical home, were certainly open to that. And folks also expressed a desire to have care close to their home and their community rather than being transported large distances. That's probably a misnomer within the small pseudo state of DC that there's large distances, period, but they wanted it local to where they were. The key really was that they wanted it to be able to provide definitive care. There was consensus that the kind of worst outcome would be being taken to a clinic or a site, and for them to say, sorry, we're not able to handle this, and then arranging a secondary transport. And families felt that that would leave them back where they started and not build trust in the system. Families were also amenable that if paramedics felt that their child was safe to be staying at home and that the kind of screening exam was sufficient, that there was a diversity of views there, but some of the caregivers felt that that in and of itself would be sufficient for them.
Thank you. For Dr. Lang, what was the initial feedback from the paramedics when they first heard of the training? And then how did that kind of change over time?
So the majority of paramedics, both green and very experienced, have said this is something that isn't, this is something you learn through the School of Hard Knocks. So the fact that there's any training on it is really important. The other thing that people tend to focus on is really the medical, like, okay, I'm running through my PALS algorithm, I'm really focused on that. And so it's a real shift when the context of the learning goes to how do you then turn off the medical brain and start really turning on the human side and really communicating with families in a context where often you have just met this family and are suddenly declaring the death of their child, or you've been working on this child for several hours, and that's the context of this. And so the focus really initially was just on very hard, like, okay, what words do you say and how do you do it? And now it has shifted a lot more to how do you communicate with families, how do you connect with families, and then how do you walk home and sleep at night after that, and how do you deal with the trauma that you see? And so that I think was surprising to us, and how much this curriculum brought a lot of those pieces up. And I think we're still going to be focusing on those hard pieces of data of how do you communicate it, while kind of enhancing our resources that we are using in the community to be able to support all of the first responders for the incredible work that they do, but the hard stuff that they go through.
And then a little bit of a follow-up question for you as well. Are you looking for additional study sites, and is the app available for other people to use?
I think that's our dream. We haven't really discussed it very much, just in terms of where we want it to head. But I think that based on initial kind of test runs of it here, based on the proof of concept that Mary Fallett et al. Did, I think it would be a really important thing. And our goal is also to make it something that is module based in a way that anyone could pick it up, that it's something that anyone could do an hour of continuing education in a department, no matter where they are. And so our hope is to make it a publicly available web app that anyone can use, and that we'll put all of our scenarios up as well, because I think it would be important if it shows success here to take it to anyone who wants to be able to use that curriculum.
And then for Dr. Goldman and Megan, how do you plan, in the poster you list that you plan to organize a statewide standardization of care project, how do you plan to do that?
Start small. honestly, pilot. We're going to work with some of our more high volume referral centers where we have established PECs and good rate relationships with as a first phase of rollout. To get a sense of what's working with it, what's not. Some centers want it electronic, some others want it, printed out, etc. So just to collect sort of some pilot information from, and then in hopes then distribute it throughout our state and see how it goes.
And then a follow-up question to that, the family discussions that you talked about earlier in this presentation, do you have scripting for those, or just because those conversations can sometimes be very difficult? So how are you approaching that with training people how to have these conversations?
That's a great thought. We haven't thought about scripting. We thought at least having the checklist to make sure that they brought up specific topics were important, but we haven't yet developed scripting, but it's a great idea.
And then for Dr. Sanchez and Morales Perez, I felt, what can we do to help?
Overall, you mean?
Yes.
That's a great question. So we are working with local government agencies and through the EMSC, the Puerto Rico chapter, to actually target some of these difficulties and this discomfort that our EMS providers have. So we will be needing support from your agencies and from everybody that's here in this call, translating some of the already available material, right? So we need protocols to treat the most common pediatric emergencies in the pre-hospital setting. So we don't want to reinvent the wheel. We just want to adapt it to our resources and to the materials that we have available in Puerto Rico. So we will be reaching out to different agencies and for your consideration to share all this knowledge and all these projects that you guys are doing so that we can adapt them to our island.
Thank you very much. We will be looking for those calls and be there to assist you. So I would like to thank all of our presenters for sharing their work with us through the Poster and Innovation Hall over these past few days. I have to say, this is probably the best group of people to work with. So you all have been so patient and flexible. So thank you very much for making this role very easy for me. As we prepare for 2022 EMSC All-Grantee meeting, please consider submitting posters for next year. This is how we share the work and show what we are doing here within this EMSC space. Up next, we're going to have a very quick break, so you can take the time to grab some coffee or some lunch, depending upon where you are, or meet with some friends in the networking chat. We will be back at 11:10 on this main stage with the plenary session on capturing the status of pediatric trauma system development. So today is packed with even more outstanding plenary and breakout sessions. So I hope you all enjoy the day.